Chapter 8, Postspirometry Test Procedures. There are a series of logical data review and quality assurance checks that technicians should do at the end of each testing session. This must be completed before the subject leaves, so that if there are any errors, he or she can blow again until good quality spirometry has been documented. These test evaluation checks are laid out in a logical step-by-step order in this chapter that is easy to follow, and will assist you in not overlooking any details that need to be checked before the subject actually leaves. These are called the 10 steps to checking your spirometry. So in chapter 8, we'll cover steps 1 to 6, and in chapter 9, we'll cover steps 7 to 10. So just a quick review of what you're going to learn in the chapter. You're going to learn step 1 about calibration and subject data checks. Step number 2 about reference values checks and ethnicity checks. Step 3, acceptability and usability checks. Step number 4 is about checking the repeatability and test quality grading. Step number 5 is looking at the lower levels of normal and the percentages for interpretation, so knowing your lower levels of normal for both Z-scores and percentage of predicted interpretations. Step number 6 is about the best curve and the best test. So let's start by looking at step number 1. At the end of this chapter, what you should be able to do is conduct and identify proof of equipment validation checks before completing test procedures. You need to understand the effects of incorrect calibration data on the test results. You need to find and indicate subject data that influences the predicted values on the test results. And you need to understand the effects of incorrect subject data entry on the results itself. So looking at this, we have learned already about calibration and we have learned about entering subject data and all the things that can go wrong when you make a mistake on entering your subject data. So a quick recap on that. To ensure that your spirometer is reading correctly, you must have conducted a linearity calibration check on the day of testing. And those records should be saved and easily accessible should you need to check them in relation to that patient's spirometry test itself. When it comes to the subject demographic data, we know that predicted values are affected by the individual's age, height, and sex, of course with the ethnicity as well. So if any of this is entered incorrectly, there's going to be errors in the test results, which if you don't check this, will go undetected. Because it's not always the same person who's interpreting the test who actually physically conducted the test. So it's very important to check that the child's details have been entered correctly. When you look at figure 8.1, you will see 2 different example spirometry reports just showing you where to check the subject and calibration details. So in the top example, the calibration data is clearly presented, and in the bottom example, the calibration data is not reported, in which case you would have to go and find the matching calibration test report should you want to double check the equipment validity, or you need to refer the patient out to another institution for further checking. So, just to re-clarify, if the entry of the subject is incorrect on the spirometer, or you choose the wrong reference values, what will happen is you'll have the incorrect predicted values and lower levels of normal. So that will then lead to incorrect Z-scores and percentages of predicted, which could lead to an incorrect interpretation, an incorrect diagnosis, and problems. So all of this begins and ends with entering the subject details. When it comes to the effect of entering the gender incorrectly, we have looked at this in quite a lot of detail in chapter 5. Reference values and ethnicity, step number 2. So the ATS-ERS guidelines say that every spirometry service should select the appropriate reference equations for the population that it serves. And we know that the Global Lung Initiative 2012 reference values are recommended globally as they are formulated using the latest statistical methods and provide a global standard. So, when you are checking your reference values, be sure that you have used the GLI Quanja 2012 reference values to measure the subject's results. The word Quanja, that is the author of the GLI 2012 reference values. For children who are not Caucasian, the GLI reference values with other should be used. This will ensure that the spirometer adjusts the actual reference values that we measure our child's values against. For persons who are not Caucasian, the reference values will be approximately 10% lower to account for chest height ratio differences between Caucasians and non-Caucasians. And on this point, just remember that the best predicted value for any patient is that child's personal best reference value. So that is the value obtained at a time when the child is well. Such personal best values may reveal that values which were within the normal predicted range are not actually the child's optimal values. See figure 2 to see what we're talking about here. So in figure 8.6, here you have an example of where you can find your reference value and where you can see the ethnicity of the patient. Let's go on to step number 3, data validation, which is starting with acceptability and usability. So when it comes to acceptability, we know that spirometry results are very dependent on patient cooperation. So maneuvers done at maximal lung volumes with maximal effort are more acceptable and repeatable than maneuvers that are done at submaximal lung volumes and with submaximal effort. So acceptability and usability criteria give objective measures to determine if the best effort and technique was used when blowing. So the goal of each and every post-bronchodilator testing session, pre and post-bronchodilator testing session, is to ensure that your patient achieves 3 acceptable FECs and 3 acceptable FEV1 measurements, even if they are not necessarily from the same maneuver. Let's look more closely at acceptability and usability. So, acceptability in spirometry is the term that we use to describe how each blow is checked from start to finish to make sure that it is of good quality. The checks are done by assessing the flow volume and volume time graphs, and we're going to discuss that in detail in a moment. Together with acceptability, you will find the term usability. And usability is the term that we use to describe when a blow did not meet acceptability criteria, but is still usable for interpretation. So for clarity, the definition of acceptability is the guideline for checking the performance of each individual blow. The acceptability of each individual FEC attempt must be checked before repeatability can be assessed. Test acceptability is always done by looking at the flow volume and the volume time graphs. That's why it's really important that your spirometer shows you all 3 of the best tests at least on the flow volume and volume time graphs so that we can measure the accuracy of the test. That means that the best and correct maneuver has been performed. So, if a child is unable to perform a single acceptable maneuver after around about 8 attempts, the norm is that testing may be discontinued, but in children you may be able to ask them to blow a few more times as long as you're not tiring the child out too much. It all depends on what the child's condition is and what their tolerance is for testing. In some cases, there are going to be maneuvers that do not meet all the criteria for acceptability or even usability, and that is the best that the patient can do on that actual occasion. And then when it comes to interpreting those tests, we need to be sure that we're interpreting the tests with the knowledge of the errors that was made and how that's going to affect the interpretation of the result. Let's look together at figure 8.7, which is a table showing the criteria for acceptability. So we have divided acceptability up into 3 different parts of the graph. So that is the start of the test, the middle portion of the test, and the end of the test. When it comes to the start of the test, we can measure the acceptability of the blow by looking at the starting point. When we look at the starting point, we want to be sure that the child has blown immediately and fast, with no hesitation from the point of total lung capacity. We can see this by measuring the back extrapolated volume. And the back extrapolated volume must be less than 5% of the FEC or less than 100 mils, whichever one is the greater. Then we look at the next section of the graph, which is the rise to peak. And this is, again, where we check that the vertical rise of the test was straight up, tall, with no hesitation, no leaks, no artifacts, no glottis closure, and that it was done very, very fast. We measure the rise to peak by looking at the time to peak, which should be around equal to or less than 150 milliseconds. So this parameter is what we can do to look at the acceptability of the rise to peak on the graph. When it comes to the peak of the test, we would like a tall pointed peak, indicating that maximum effort was given by each patient. And there should be no artifact on the peak either. Let's look at the middle portion of the test. So the middle portion of the test is looking at the downward curve. The downward curve of the blow should be smooth and continuous with no cough, no leak, no tongue in the tube, no teeth biting, not biting the mouthpiece too hard or any glottis closure. So the downward curve should be absolutely smooth and continuous with no artifacts at all in that portion of the graph. Then we come to the last part of the graph, which is the end of the test. And this is either the end of forced expiration or it is the end of the test when the patient has breathed in again to total lung capacity. So when it comes to looking at the end of forced expiration, we want to be sure that the child blew out completely to residual volume. So the flow volume graph should descend gracefully onto the x-axis with no drop-off. The volume time graph should reach a plateau, or each blow should end at exactly the same time on every single blow. More specifically, we have very, very specific end of test criteria which we need to achieve with each and every patient. And these are as follows. The child needs to either have an expiratory plateau of at least 1 second. If they don't have an expiratory plateau of at least 1 second, they must have blown out for at least 15 seconds. If they do not have a plateau of 1 second, or they have not blown out for at least 15 seconds, then we need to look at the FVC and see that it's within repeatability tolerance, that is no greater than 150 mils of a prior FVC in the same testing session. So you can see we have very clear, specific criteria for acceptability. I'd like to just take a moment to make sure that you fully understand the terminology when it comes to looking at the quality of the blow itself and understanding these criteria for acceptability. So the first definition that I want to go through, or abbreviation, is the back extrapolated volume. That's the BEV. And the BEV is the volume of gas that has already been expired from maximal lung volume to the point of time zero and is included in the FEV1 and FVC measurements. So to ensure that the FEV1 comes from a maximal effort, the BEV must be less than 5% of the FVC or 100 mils, whichever is the greater. The FEV1 and FVC measurements from a maneuver with a BEV that exceeds that upper limit is neither acceptable nor usable. A large back extrapolated volume will usually result in an erroneously high FEV1 because the patient is blowing more slowly, so therefore the resistance of the airways is not correctly measured. The next one that I want to clarify for you is the rise time. So the peak expiratory flow should be achieved with a sharp rise and occur as close to time zero as measured by the rise time from 10 to 90% of the peak flow, and that should be less than 150 milliseconds. An alternative to using the rise time to assess acceptability would be to use the peak expiratory flow time, which should also be equal to or less than 150 milliseconds. Let's look at what the end of forced expiration means. So if the patient cannot expire long enough to achieve a plateau, then a child with high elastic recoil or patients with restrictive lung disease, they often cannot blow very, very long to achieve that plateau. So then we need to measure whether the end of forced expiration has actually been reached. In other words, are the lungs completely empty when the patient comes off the mouthpiece? So for within maneuver acceptability, the FVC must be greater than or within repeatability tolerance of the largest FVC observed before this maneuver in the current testing session. So maneuvers that do not meet any of the end of forced expiration acceptability criteria will not provide acceptable FVC maneuvers. However, an acceptable FEV1 measurement can still be obtained from a maneuver with an early termination or a glottis closure, as long as it's not in the first second of the blow. For children who are aged 6 years and younger, an acceptable FEV 0.75, so that's the volume of air measured at 3/4 of a second, may be obtained from a maneuver with early termination after 0.75 seconds. So what that means is that if there is an error in the FEV1, we can still use the FEV 0.75, 3/4 of a second. A cough during the first second of the maneuver can affect the measured FEV1 value, and the FEV1 from such a maneuver where there is a cough is neither acceptable nor usable. However, you may still be able to use the FVC. When it comes to glottis closure or early termination, such as when a patient inspires too soon or has just come off the mouthpiece, this renders the FVC unacceptable, and if it occurs in the first second of the test, it also renders the FEV1 unacceptable and unusable. So a similar thing, if the termination occurs in the first 0.75 seconds of the blow, the FEV 0.75 is also not acceptable and not usable. When it comes to a mouth leak, so there's a little leak at the side of the mouth when the patient's got the mouthpiece in the mouth, we don't want a leak from the mouthpiece. So patients who have difficulty making a seal around the mouthpiece with their lips might need that silicone mouthpiece that I was telling you about earlier. Sometimes we might see obstruction in the mouthpiece by the tongue. So lots of children will put their tongue into the mouthpiece, or they might put their teeth in front of the mouthpiece, or they can bite so hard on the mouthpiece that it actually distorts the mouthpiece and it distorts the flow of air through the airways. Now, any of these errors are going to affect the performance of the result. So any errors occurring because of obstruction need to be discarded. When it comes to a zero flow error, remember that zero flow is a measurement of airflow by the spirometer before the patient actually starts the blow. So the environment needs to be very calm so that when the zero flow is being measured, the baseline flow of air is being measured, there is zero airflow, so that the machine is able to switch off the test correctly at the end of the blow. So in other words, if there is a faulty zero flow setting before the start of the test, it means that the spirometer may not recognize the end of test correctly and may not stop the testing session at the correct moment, in which case it will carry on reading a higher and higher reading or a lower and lower reading, which would be incorrect. Now remember with acceptability that if the person is unable to perform a single acceptable maneuver within about 8 blows or so, you need to maybe discontinue testing, give the child a break, and then bring them up to do additional maneuvers later on, and all depending on their agreement. I'd like you to take a look at figure 8.8. There you will see examples of acceptable spirometry flow volume loops when compared to the very first one, which is an acceptable effort. So in the top row, the second example on the left, that shows submaximal effort. You can see where the flow volume graph is rounded at the peak of the graph. In the third one, on the top row, you see that these are examples of a patient who perhaps hasn't breathed in to total lung capacity before blowing their air out. You see how the curve follows the same shape, but every single one of the tests is a little bit smaller than the one before. In the fourth example, on the top row, you see a clear cough. In the first example, on the bottom row, you can see that the start is not rapid. When the test rise to peak falls to the right like that, you can see that the starting point was not good. In the second example on the bottom row, you can see that the test stops prematurely. So either the patient has terminated the blow early, or there is glottis closure causing the early termination. And you can see that where the flow volume graph descends onto the x-axis, there's a sudden drop-off there. In the third example on the bottom row, there is submaximal inspiration. You can see that the FVC is smaller than the FIVC. There's a discrepancy there. In the fourth example on the last row, you can see that there's possibly an occlusion of the mouthpiece by the tongue. The graph is very rounded. So those are good examples of some of the problems that you can see on gaining acceptability when the child is blowing. Usability. The definition for usability is the criteria applied to blows that have not met acceptability criteria to see if they can still be used for interpretation. So when every effort has been made to achieve 3 acceptable blows, but acceptability criteria has not been met, the technician may assess the child for usability. FEC and FEV1 are assessed separately for usability. In some instances, the FEC may be used for interpretation, but not the FEV1, and vice versa. So maneuvers, for example, that do not meet any of the end of forced expiration acceptability criteria will not provide acceptable FEC measures. However, an acceptable FEV1 measurement may be obtained from a maneuver with early termination after 1 second. A cough during the first second of the maneuver can affect the measured FEV1 value, and the FEV1 from such a maneuver is neither acceptable nor usable. However, the FEC may be acceptable. Glottis closure or early termination, such as inspiration or coming off the mouthpiece, renders the FEC unacceptable, and if it occurs in the first second, renders the FEV1 unacceptable and unusable. In figure 8.9, you will see the table of usability criteria taken from the ATS ERS Standardization to Spirometry 2019 update. There you will see very specific criteria for each of the FEV1 and the FEC for acceptability, and then separately for usability criteria. So you can always refer back to this graph to have a good look at your acceptability and usability criteria. So I'd just like to say a few words again about the importance of getting a valid test. So you know that the goal of each pre-bronchodilator testing set and post-bronchodilator testing set is to achieve a minimum of 3 acceptable FEV1 and 3 acceptable FEC measurements. Note that acceptable FEV1 and acceptable FEC measurements are not necessarily from the same maneuver. Some spirometry errors will falsely elevate the FEC and or the FEV1. For example, excessive hesitations, extra inhalations through the nose, contaminated sensors or wet sensors, over-recorded flows caused by zero flow errors. And it is important to reject any of these curves because the spirometers will naturally always use the largest test on record to interpret the test result. Other errors, such as submaximal inhalations and weak expiratory pushes, often falsely reduce the FEC and FEV1. So spirometers usually discard such falsely low values when good coaching leads to higher, more accurate results on subsequent maneuvers. Even if it leads to a reduced FEV1, coughs in the first second of exhalation make the graph unacceptable. Again, in figure 8.10, we've got a clear flow chart for you to look at, which outlines the end of forced expiration criteria, acceptability criteria for the FEC. So I've been through this with you. You need to achieve a 1-second plateau, or you need a 15-second push out, or failing both of those, you need the FEC to be within the repeatability tolerance of a previous FEC on record in the same testing session. FEC may meet the end of forced expiration usability criteria if one of these criteria are reached. Figure 8.11 is an example of acceptable and usable maneuvers, and what you'll see is that 6 specific areas have been assessed. The start of the test is number 1, it is smooth and unhesitating. Number 2, we've looked at the rise to the peak of the test. Number 3, we've looked at the tall pointed peak of the test. Number 4, we've looked at this downward curve of the test. Number 5, we've looked at the end of the test to make sure that there's no early termination. And on number 6, we've looked to see that there is a 1-second plateau or a 15-second push out, or the FEC is within 150 mils of the previous FEC. And what you can see is that on each one of these 6 parts of the spirometry maneuver, there are 3 ticks to indicate that acceptability was checked on each and every blow individually. On the other hand, in figure 8.12, you can see an example of unacceptable and unusable maneuvers. At the start of the test, there is one blow that has a hesitant start. The rises of the test look alright, and the peaks look okay, but in the downward curve there is coughing throughout. And in one of the tests, there is early termination. And you can see this far more clearly on the volume time graph as well. On figure 8.12, there's no acceptable and there's no usable maneuvers. In figure 8.13, you can see an example of high back extrapolated volumes. So in trial number 6, the back extrapolated volume is within the range allowed. But trial 2 is discarded, probably because the test wasn't accepted. You can see that it has a line through it, which means that it's not usable. And in trial 4 is also not acceptable or usable. But I just wanted to point out here that the back extrapolated volume is higher than 0.15 liters, and it's higher than 5% of the FEC. So if you had to calculate 5% of this FEC being 2.65, you would find that it is far less than the back extrapolated volume of 0.19 liters in this test. In the figures to follow, you will see a whole lot of different errors on different maneuvers that children have conducted. I'd like you to take a moment and look at each one of these examples one by one and see if you can identify what the testing errors are. Let's have a look at common problems that patients experience when they blow and the actions that you can take to correct them. So in the first example, you can see the problem being inadequate or incomplete inhalation. And this is almost always the most common error that I see when testing patients in general, including children. So what you'll see is that there's a smaller exhaled total volume, which means there's an underreporting of the true spirometry results, resulting in a falsely reduced FEC, and this is sometimes misinterpreted as a restrictive impairment. And also you'll often find failure to achieve repeatability. So what you need to do in this instance is coach that subject to fill his lungs completely, hold for a moment, and then be sure to blast the air out as fast as he can for as long as he can. In the next example, you're looking at a slow or a hesitant start, and in this case, you might find an excessive back extrapolated volume or even an increased peak expiratory flow time. And this is because the back extrapolated volume is high at the beginning of the spirometry effort and becomes more indeterminate, and the FEV1 is more likely to be overestimated. The volume of air expired is unacceptable if it exceeds 0.15 or 5%. VEXT is another term for back extrapolated volume. So in this instance, you need to coach the subject to breathe into total lung capacity, wait less than 2 seconds to be sure that the lungs are absolutely full, wait less than 2 seconds, and then blast the air out. as immediately and as fast as they possibly can. Look at the next example, which shows a lot of tests with submaximal effort. Now, when there's submaximal effort, you will get a falsely low FEV1 and a falsely low FEV1 FVC ratio. This can sometimes be misinterpreted as an obstructive impairment, and again, you will have a failure to achieve repeatability criteria. So in this instance, the peak is rounded and much lower than other blows. In this instance, you should coach the lung to fill his lungs completely and then blast the air out as fast and hard as he can. Looking at a cough in the first second of the blow, this will falsely reduce or falsely elevate the FEV1, causing an inaccurate FEV1 and FVC, and the ratio of the FEV1 to the FVC. This can be misinterpreted as an obstructive impairment, and again, you will have a failure to achieve repeatability criteria. A cough is seen by a jagged downward curve, and this can be either just one cough or there could be multiple coughs. So it's difficult to manage. Try to give the subject a drink of water or ask them to cough and clear as much as they can and a lot of the irritation from their test. Look at the next example. What you'll see here is that this patient has blown out completely and then taken 2 extra breaths. This will cause the FVC to be falsely elevated. The FEV1 shouldn't be affected in this instance because the extra breaths occur after the FEV1 has been completed. Use nose clips, instruct the subject to keep a tight lip seal on his mouthpiece, and then delete any incorrect curves. These curves can't be used at all for FVC, but only for FEV1. Let's look at what happens when we have a positive zero flow error. So remember that this is when the machine does not recognize the end of test correctly because the baseline zero flow was not measured correctly. And this will result in there being no close off of the test by the spirometer. So the spirometer just keeps on reading and reading and reading a higher and higher volume. So what you need to do now is delete this test. You're not going to be able to use it for FVC. You may still be able to use it for FEV1. And you need to go back and block the sensor of the spirometer when the zero flow reference is being set. Let's look at the next one. The next one shows a negative zero flow error. This is basically exactly the same thing as a positive zero flow error, but instead of the spirometer continuing to read higher and higher readings, it starts to read lower and lower readings, resulting in you reading a very low FVC maneuver, which causes a falsely increased FEV1 to FVC ratio, and this can be misinterpreted as a restrictive impairment. You need to go back, block the spirate or the mouthpiece when you are measuring zero flow so that the baseline flow is measured correctly. Looking at glottis closure. Glottis closure is when there is an abrupt cessation of flow during the test for one or another reason. Either the patient just stops early or they have a closure of the glottis in the airway which causes an immediate termination of the FVC maneuver. In this instance, the FVC is falsely reduced, which leads to a falsely elevated FEV1 FVC, and this can be misinterpreted as a restrictive impairment. In this instance, you need to give the person a drink of water and ask them to carry on blowing completely until the lungs are absolutely empty. What happens in early termination? If the patient simply stops blowing before the lungs are empty, this will cause a falsely reduced FVC, and in turn will cause the FEV1 FVC to be increased, leading us to think that this is a restrictive impairment, and this is a false interpretation if there is indeed early termination. So, coach the subject to keep blowing until he is told to stop, and they should just keep forcing against that resistance until the lungs are absolutely empty. What happens when there's an obstruction of the mouthpiece by the tongue? So the mouthpiece is then partially blocked by the subject's tongue going into the mouthpiece, or the teeth are biting too hard, or the teeth are in front of the mouthpiece, and this is going to cause the FVC or FEV1 to be reduced. And this could be interpreted as an obstructive impairment. So you will see misshapen graphs in a variety of ways, depending on what the error is. And really what you have to do as the technician is recognize the errors and coach the subject to place the mouthpiece between the teeth, keep the tongue out of the way, do not bite too hard on the mouthpiece, and then you should get the correct reading thereafter. Vocalization during the test is when the patient almost blows with too much effort. So normally a patient would blow like this. Okay, but in vocalization, the patient will often do this. Okay, so they blow the air against the back of their throat. This causes a partial glottic closure, obstructed airflow, and data that is not repeatable. So this will reduce the flows and must be discouraged. So you need to make sure that the patient is sitting upright and performing the maneuver with the neck extended and the throat open. Right, let's go on to step number 4, which is looking at repeatability and the test quality grade. So repeatability refers to how alike tests are one to each other in the same testing session. So it indicates that the subject has used the same effort and technique every single time they blow. And repeatability criteria varies for younger children to older children. So in children who are over the age of 6 years old, so from 7 years and above, we want the highest FVCs in one testing session to be within equal to or less than 150 mils highest to the next highest. And exactly the same for the FEV1. We want the highest to the next highest FEV1 to be within 150 mils. In children who are younger than 6 years of age, who are 6 or younger, we want the difference between the highest FVC and the second highest FVC to be less than 100 mils or 10%, whichever is the largest. And the same with the FEV1. We're looking for less than 100 mils, highest to next highest FEV1, or 10%, whichever is the highest within that one testing session. So FVC repeatability is achieved when the difference between the largest and the next largest FVC is less than 100 mils if you're over 6, or less than 150 mils if you are over 6 years of age, or 100 mils or 10% if you are smaller than 6 years old, and exactly the same for the FEV1. If these criteria are not met in 3 maneuvers, additional trials must be attempted to try and get repeatability criteria. So let's just look at this table to show us how we actually assess repeatability on the spirometry report itself. So where we can see the graphs, we look at the flow volume and volume time graphs, and we want to be sure that first of all, acceptability criteria has been met. Secondly, there must be a minimum of 3 blows. And lastly, ideally the graphs should be superimposed. Once we've established that that's been done, then we can go and look at the numerical values on the measurements of spirometry. And again, exactly as I said, FVC repeatability is then assessed by looking at the highest to the next highest FVC and the highest to the next highest FEV1. There is one exception to getting repeatability criteria on a test, and that is when you have noted blowing-induced bronchoconstriction on the testing session. So as I said previously, if the child has blowing-induced bronchoconstriction, they usually become symptomatic, and if the FEV1 drops to less than 80% of a previous FEV1 on record, and you're sure that that's not because of effort and technique, but it is truly bronchoconstriction, you will not worry with repeatability criteria. You will stop the testing session and make a note on the report as to what happened. So let's look at the spirogram of a 12-year-old child in figure 8.20. Let's look at the repeatability here together. So on the flow volume and volume time graphs, there are a minimum of 3 acceptable blows which are superimposed. All the blows have smooth, unhesitating starts, rapid upward rise to peaks, tall pointed peaks, smooth continuous downward trials, and plateaus on the volume time graph. The highest FVC value of the 3 best blows is 2.27 liters in trial 1. The second highest is 2.23 liters in trial 8. The difference between the highest and second highest FVC is 40 mils. And as this is less than 150 mils, the FVC is repeatable. In the same way, the highest FEV1 value of the 3 blows is 2.01 liters in trial 1. The second highest is 1.95 liters in trial 8. So the difference between the highest and second highest FEV1 is 60 mils. As this is less than 150 mils, the FEV1 is repeatable. So both the FEC and the FEV1 fall within the allowed range of 150 mils, highest to next highest, so the test is repeatable. In the example spirogram in figure 8.21, on the other hand, this shows a set of blows that are neither acceptable nor repeatable. The validity of the test is assessed as follows. On the flow volume and volume time graphs, there are a minimum of 3 blows, but they are not superimposed, and they do not meet all the acceptability criteria on each and every blow. So already we know that this test cannot be assessed for repeatability because we do not have acceptability. We need to go back, get the child to blow again, and once we have 3 acceptable blows, we can then assess repeatability. In saying this, let's assume that the child had blown again and that we had achieved acceptability on these tests. Let's look at the numerical values just as an exercise to do together. The highest FEC value of the 3 blows is 3.92 liters and the second highest is 3.91 liters. So the difference between the highest and second highest FEC is 10 mils. As this is less than 150 mils, the FEC would be repeatable, remembering that this only applies if you have achieved acceptability criteria on the blows. The highest FEV1 value of the 3 blows is 2.70 liters, the second highest is 2.50 liters, and the difference between the highest and the second highest FEV1 is 200 mils. So we can see from this that using the numerical values, the FEV1 would not be repeatable, which means the test is not repeatable. What would you do? You would encourage the child to do further blows for you. Okay, so when we finished with checking acceptability and usability and or repeatability, we would then go on to looking at the test quality grading. And as explained in the last chapter, you would use the test quality grading table to assess the quality grade of this test itself. Now looking at figure 8.23, you can see that this test is a quality grade A. Why? Because there are at least 3 acceptable blows and the highest FEC to the next highest FEC is within 150 mils and the highest FEV1 to the next highest FEV1 is also within 150 mils. So just a couple of reminders about test quality grade. The repeatability grade is determined for pre and post bronchodilators separately. The repeatability criteria applied to the differences are between the 2 largest FEC values and the 2 largest FEV1 values. A grade U indicates that only usable but not acceptable measurements were obtained, and although some maneuvers may be acceptable or usable at grading levels lower than an A, the overriding goal is always to achieve the very best that that patient can do, and then to interpret the test understanding those testing errors. So just to recap on this data validity, such an important section of what we learn in spirometry, acceptability is the guideline for checking the performance of every individual curve one by one. Usability is the criteria we apply when acceptability criteria has not been met. Repeatability is the closeness of each blow one to the other, indicating that the same effort and technique was used on each and every blow. And then lastly, the test quality grade is the level of confidence that the spirometry results represent. Good. So let's go on to step number 5, knowing your lower levels of normal. So we are starting to step towards interpreting our spirometry test result. And before we do that, we want to be sure that we know the lower levels of normal for each one of the key measurements of spirometry. And we can do this by using this table in figure 8.24. So the lower level of normal and Z-scores, for every single measurement of spirometry to be normal, the test must be equal to or greater than 1.64 Z-scores. When we're using percentage of predicted to interpret, which remember is always a second choice, the cutoff values are 80% of predicted for the FEC, 80% of predicted for the FEV1, a cutoff of 70% of the actual ratio of FEV1 to FVC, 80% are predicted for peak expiratory flow rate, and 65% are predicted for your forced expiratory flow between 25 and 75% of the FVC. So have a good look at figure 8.25, which shows those lower levels of normal and then shows the percentages of predicted and the Z-scores where those will be read from when we get to interpretation in step number 7. Looking at step number 6, we need to understand which values to choose for interpretation, and that brings us to choosing the best test or the best trial for interpretation. So in a spirometry test, the FVC and FEV1 are measured and then interpreted from a series of at least 3 acceptable forced expiratory trials. There are 2 ways of choosing the data for interpretation, and these are known as the best test and the best trial. So looking at those one by one, the best test is a new test created by the software of the computer, which takes the highest FVC value and the highest FEV1 value from 3 best acceptable blows, even if they do not come from the same blow. So the FEV1 FVC is then calculated using these 2 values. This new test is then used to derive other variables if required for diagnostic purposes or interpretive purposes, for example, using the peak expiratory flow and the FEF 25 to 75%. So just a note on using the best test when it comes to children. So children aged 6 years or younger have relatively large airways compared with their lung volume and may complete expiration in less than 1 second. Therefore, the FEV1 0.75 and the FEV 0.5 could be used instead of the FEV1. So in children 6 years or younger, the FEV 0.75 has been found to provide information very similar to the FEV1. GLI reference values for FEV 0.75, but not yet for FEV 0.5, are available for children aged 3 to 7 years. And the FEV 0.75 should be reported for children aged 6 years or younger. And if the FET is less than 1 second, then the FEV1 should also be reported. Now, if your spirometer for some reason does not read the best test or is not set up to read the best test, then you would use the best trial for interpretation. And the best trial is the blow from an acceptable curve with the largest sum of FVC and FEV1 of the 3 best blows. Just a quick note before we look at an example of that is that if you are looking at the peak expiratory flow to assess the quality of the data, the best peak expiratory flow comes from the largest value from all maneuvers meeting acceptability criteria. And the FEF 25-75% is reported from the maneuver with the largest sum of FEV1 and FVC. So all software should create a best test using the highest FVC and highest FEV1, even if they come from different curves. But many spirometers have default set to something else. And I encourage you as a user or an operator to review your settings and ensure that your machine is set for the best test method when it comes to interpretation. So just to recap, the best test is the test created by the software using the highest FVC and highest FEV1 from all acceptable trials, even if they come from different curves. And the best trial is the test from an acceptable curve with the highest sum of FVC and FEV1. Now, to illustrate these points in table 8.25, you will see that the best blow is trial 4, which is the new blow with the highest sum of FVC and FEV1. The best test, however, is a new test created by the software comprising the highest FVC of the 3 best blows, which is, in this instance, 4.04 liters from trial 4, and the highest FEV1 from the 3 best blows, 3.04 liters from trial 2. So this creates a new FEV1 FVC ratio of 75.3%. These are the values that are measured against the predicted values and the lower level of normal, and then expressed as a z-score or a percentage of predicted for interpretation. In figure 8.26, you'll see a spirogram example where the best trial only is displayed for interpretation. All right, so we have completed chapter 8. We've looked at test validity and which data you're going to use for interpretation. And now we go on to chapter number 9, where we interpret the spirometry test.